Hello, I'm Dr. Ken Landau. Thanks for joining us. This is Well Now Doctor. We're going to be discussing hepatitis C. This is a continuation of our discussion from a previous show. What we have decided is hepatitis C is obviously it's a virus infection. It's a virus that affects principally the liver, hence the name hepatitis. We've only recently become aware of it. It was only first discovered, as you will, in 1989. Hepatitis C affects a significant number of people worldwide, maybe as many as 170 million. Maybe the number is really only 60 million. Argument about that. We know that throughout the world, maybe as many as 350,000 people are going to die every year because of hepatitis C. We know in the United States, it's estimated that the infection rate is somewhere around 2.5 million to 3 million. We know that somewhere between 3,000 and 17,000 people are going to die because of hepatitis C. But that means the overwhelming majority of people with the infection are not going to go on to develop any significant medical issue. On the other hand, we know that if it does progress, it may lead to cirrhosis of the liver and complications of hepatocellular carcinoma, cancer of the liver. So we know that that's obviously a major issue. Well, it's very important to realize that not all people who are infected with the virus need to be treated. And the question is, we have to decide ultimately who's going to get the treatment, especially because we know that the cost of therapy for one individual is going to be well in excess of $100,000. And we know that if all 2.5 million or 3 million people get treated for a condition that isn't going to cause them any problem over the course of a lifetime, that we're going to expend a significant amount of resources we really don't even have. So the idea that we need to develop is not all people with the infection need to be treated, but many of them do. And who are those people? What are the symptoms? Now, we've already decided that people who are infected with the hepatitis C virus, the overwhelming majority going to get the virus, and they're not going to become aware that they're infected. They're going to have absolutely no symptoms. They're not even going to get what we call acute hepatitis. The virus is just going to go into the system, go to the liver, and it's going to do some things in the liver, maybe cause a little mild inflammation, and it's going to do nothing for a period of 20, 30, or 40 years. In some people, because of genetic proclivity, either of the individual or the virus, it's going to progress. Well, obviously, we need to catch those people, to identify those people. And as a result, the government has come up with the idea that all individuals born between the years 1945 and 1965 ought to be tested, because that's the significant target group for infection. They have the highest rate of infection in the United States. And then we also know that those people who are intravenous drug abusers, those people are exceptionally likely to become infected. And reinfected, by the way, once treatment is given. Well, what's the likelihood that the virus is going to progress once it's in your system? We already said that once you're infected, the virus doesn't have to go on to cause any kind of major problem. But we know that a substantial number of individuals, somewhere between maybe 5 and 10, 20, 30%, of those individuals in select groups are going to progress to develop cirrhosis of the liver by 30 years from then. Well, who's at increased risk? Because we know all members of society are not created equally. So we know that those people who drink alcohol, who consume alcohol, those people are at greater risk for developing problems. Now, we know that the likelihood of developing cirrhosis of the liver, well, if you drink enough, that's a substantial risk factor. As a matter of fact, it's estimated that if we look at all the people who have cirrhosis of the liver, we find about 20% have cirrhosis because they drink too much. And if you happen to drink too much and you happen to have an infection with hepatitis C virus, that hepatitis C is going to progress more rapidly. And if you're infected when you're a little bit older, so the first time you come in contact with the virus happens to be when you're more than about age 40, then the virus also, for unknown reasons, seems to be more rapidly progressive. And we know that cirrhosis of the liver is a condition that has a tendency to occur in people who are fat. So if you enjoy consuming all of those fast foods, if you enjoy the pizzas and the fried chicken and all of the other things that we so frequently consume in our society, and you consume them to excess, and you become overweight, you become fat, obese, then we know that you increase your risk for developing cirrhosis just because of the obesity. The fat cells not only sit in your belly, they also sit in your liver. And when the fat cells sit in your liver in excess number, those fat cells lead to inflammation, and that can lead to cirrhosis. We call it non-alcoholic steatohepatitis, and that progresses to cirrhosis. Well, we know that if you combine the two, if you combine the hepatitis C and you're overweight or obese, that you increase your risk for progression to cirrhosis. And if you happen to be infected with the HIV virus, the AIDS virus, then we also know that you can progress, and you can progress quite rapidly over a period of relatively short time to develop cirrhosis and then go on to have other complications as well. If you have an infection at the same time with the hepatitis B virus, you're at greater risk of progressing to liver complications. And for whatever reason, if you're a man, you have a greater likelihood of becoming infected. Now, in order to determine the likelihood that the disease is going to go on and cause you problems, we have to look at some studies that were done quite some time ago and evaluated people who were followed over a long period of time. And one of the studies was performed originally, 1948 to 1954, when military recruits were evaluated. They were evaluated for Group A strep rather, and acute rheumatic fever. Well, they had blood drawn, and there were about 8,500 individuals who had blood drawn and stored and frozen. And the VA, after a period of about 45 years, went back and evaluated the blood for hepatitis C, the antibodies and the virus, and then checked on the individuals to see what happened to them. And what they found was that 17 of those individuals were infected at some point in time with the hepatitis C virus, and they found that it was more common in people of color than it was in Caucasians. They found that about 65% of the people who had the antibodies to the virus, which means they were exposed at least at some point in time, about 65%, two-thirds of those individuals still had the virus in the system, and the virus was the typical genotype that we find here in the United States. And it was found that of those people who were infected with the hepatitis C virus, about 12% had some evidence of liver disease during the course of time. And if we look at the people who were not infected with the hepatitis C virus, still a significant number of them, actually 205 out of the 8,000 or so that remained, well, they had some sort of liver disease as well. That was only about 2%, so 2% versus about 12%. If we look at the likelihood of death over the time of follow-up, well, the likelihood of death was about 40% in those people who were infected with hepatitis C, and it was about 30% in the people not infected with hepatitis C. If we look at the use of medical care during follow-up, the number of outpatient visits or the compensation for medical disease, well, you find that it's about the same in those people infected with hepatitis C and the people not infected with hepatitis C. Now, when they looked specifically at the people who died who were infected with hepatitis C, what they found was only one person died because of a liver disease. And whether that liver disease was related to hepatitis C or not, can't say, but at least one person died because of liver disease or with liver disease. And that means about 16%. If we look at the number of people who died without any evidence of liver disease, it was about 70%. So are we saying that 16% of the people die because of the hepatitis C? No, over a period of time, certainly in the veterans population, we know that there's a significant risk of liver disease caused by any number of factors. Now, we know if we evaluate an individual and we perform some sort of a study, and the study could be a liver biopsy or some other kind of a study, and we find that that person does not have significant fibrosis, significant scar tissue forming in the liver, that the likelihood of that person going on to develop significant liver disease, cirrhosis, or liver cancer over a period of 20 years is extremely small. And we also know that if you're going to develop the liver cancer, that overwhelmingly you must have cirrhosis first, whether you have the cirrhosis from drinking too much alcohol or hepatitis B or hepatitis C or from some drug or some other kind of a cause. You have to have the cirrhosis before you get the liver cancer, the primary liver cancer. Obviously, remember, we're not talking about liver cancer that spreads from the colon or from the breast. Now, as time goes on, or perhaps because of your genetic makeup, or perhaps because of the virus's genetic makeup, some people will develop more active fibrosis of the liver. And we call that bridging fibrosis. And in those people who have bridging fibrosis, or in those people who have cirrhosis, obviously there's an increased risk of significant complications. So one of the things that we can do to decide who needs treatment and who doesn't need treatment is follow what's happening to your liver. That's one thing. Now, let's look at another study that looked at people who were infected because they received a rather large inoculum. In other words, they had a transfusion, and the virus was transmitted during a transfusion. Well, on a follow-up over a period of many years, almost 40 years, it was found that the likelihood of those people dying because of liver disease was only about 6%. The likelihood of those people dying from non-liver related causes, well, maybe about 30%. But again, looking at people who were sick enough to require transfusions. Now, if you develop cirrhosis of the liver, if you're one of those unfortunate individuals who goes on from hepatitis C to develop cirrhosis, what's the likelihood that you'll make the next step? That you'll go on to develop a problem of liver cell cancer. Well, the good news is that while maybe 5% or 10% or 20% of the people can go on to develop cirrhosis, the likelihood of progressing even further to develop liver cancer is only 1 or 2 or 3 or maybe even 4%. So a very, very small number going to go on. Now, in those people who develop cirrhosis, there is a higher chance of developing symptoms from cirrhosis. Now, here's a problem, you see. If you're infected with hepatitis C, and if you progress to cirrhosis, not only does that entire time period potentially occur without any symptoms, so you don't have any symptoms and you can develop cirrhosis, you can have cirrhosis and have cirrhosis with no symptoms either. It's only when you develop decompensated cirrhosis, when something else happens to make you turn the step and make you develop either bleeding disorder or the liver cells become incompetent and they can't work and they can't do what they're supposed to do, then you develop decompensated cirrhosis. Then you have an increased risk for progressing. But if you develop cirrhosis and if you're treated, we know that even when you develop cirrhosis, the treatment can prevent or at least significantly reduce the likelihood that you're going to develop significant liver complications. Now, what happens when you're acutely infected? Okay, when the virus enters your body, it typically causes no symptoms. We said that maybe 25% of the people might develop symptoms of acute hepatitis, standard kind of symptoms. Well, we know that the likelihood of your becoming infected without any symptoms is 75–80%. So significant number of people going to go on from infection and they'll develop chronic disease. What's the likelihood of the chronic disease going away, of your body being able to handle it? Well, acutely, maybe about 20% of the people going to be able to achieve success. the body's going to be able to take care of the hepatitis C. It's just going to be like any other kind of infection. You're infected with the flu virus, you're infected with the common cold virus, your body handles it, goes away. Well, if it doesn't go away immediately, over a period of time, it's very rare for it to go away. It's probably going to stay there forever. And as it stays there forever, it's probably going to cause some hepatitis, some inflammation of the liver. But just because it causes inflammation of the liver doesn't necessarily mean that you're going to have any symptoms. And as a matter of fact, the overwhelming majority of people have some limited amount of fibrosis. And remember, we said when you have limited amount of scar tissue, nothing bad is going to happen. Maybe some people are going to have some non-specific symptoms. They might have some symptoms of fatigue or something like that, but not significant enough to notice. Severe complications, well, they're going to be relatively rare. And remember, we said that to develop the stage of cirrhosis, that's only going to occur in somewhere around about 10% of the people. Now, overall, we have the onset of accumulation of fibrosis. And early on, that's going to be silent. And it's going to slowly progress to a point where you can develop the cirrhosis. But we know that it could occur more rapidly than usual, because you do something that really ticks your liver off. Ticks it off because, as I mentioned before, maybe you drink too much alcohol, maybe you're too fat, maybe you have an infection with another kind of a virus as well. Maybe you're infected with the hepatitis A virus or the hepatitis B virus, or maybe you're a little bit older at the time you become infected, or maybe because the strain that you're infected with happens to be a nasty strain. So let's look at 100 people who were infected with the hepatitis C virus. We know that somewhere between 75 and 85 of those individuals are going to go on and they're going to develop chronic disease. Now, that means the virus is going to stay in the system. About 60 or 70 of those individuals are going to develop some kind of liver disease, but in the overwhelming majority of people, just like with being too fat, that liver disease is not going to cause any symptoms. A small percentage, somewhere between maybe about 5 of those 100 up to maybe max 20 of those 100 going to develop cirrhosis of the liver, and 1, 2, 3, 4% going to develop the liver cell cancer. So the chronic disease causes no symptoms or might cause a few non-specific symptoms. Remember, we said fatigue or maybe some nausea or anorexia or, in some cases, signs of cirrhosis. Now, the question is, what happens if you're co-infected with another kind of hepatitis virus? Well, could absolutely not have any effect on the progression, or it could lead to more severe disease. And the condition that seems to be most traumatic to the liver, the combination of viruses, happens to be when you're co-infected with the HIV virus. It will take a slowly progressive condition and make it significantly more active. And the question is why? And it seems that it has to do either with the virus itself living in the liver or the inflammation that the virus causes. And then the inflammation, not particularly the virus, but the inflammation causes the problem. Now, if you happen to have the condition where you're infected, well, what are some of the other things that should happen? Are you necessarily afraid of taking other kind of medicines? No, not really. Common kind of drug would be the statins. Can you take a statin drug that can affect your liver and can cause some liver problems? Well, the answer is sure, you can take some statin drugs. You can take the medicines to reduce your cholesterol if you're co-infected with the HIV, the HCV, the hepatitis C virus. But if your liver enzymes are a little bit too high, you got to be a little bit careful. What about taking acetaminophen? You hear so much talk about how acetaminophen, Tylenol, can cause liver injury. Well, if you have hepatitis C, yes, indeed, you can still take the Tylenol or acetaminophen. Just take it in a standard dose and take it only as necessary. Probably not the greatest idea to take aspirin or ibuprofen or those kind of drugs, especially if you have certain liver injuries, especially if you have cirrhosis because of the bleeding disorder, especially with aspirin. And if you're talking about taking pain pills, it's not a great idea to take pain pills, especially in the narcotic family, the Vicodin and the Percodan, those kind of medicines, if you happen to have substantial liver disease, because that can cause a hepatic encephalopathy. That's not a good thing to have. Now, cirrhosis of the liver Cirrhosis of the liver probably occurs in about 1 million people here in the United States. The likelihood of cirrhosis coming from hepatitis C, relatively small. Get back to that point every time. We don't have a substantial number of people who will develop cirrhosis. The overwhelming majority of people are going to do just fine. Now, what happens if you do develop cirrhosis of the liver? Well, cirrhosis of the liver may be totally asymptomatic and you can live the rest of your life normally without any kind of problems, but if you happen to have an added insult to your liver or in the natural progress of things, then you might develop what we call hepatic decompensation. You see, that scar tissue, the fibrosis that occurs in the liver, is going to interfere with the liver cells' ability to do what they're normally supposed to do, and that can cause portal hypertension, that can cause some bleeding disorders. Seems that it can go on for whatever reason. We're not exactly sure what the reason is, but that can increase your risk of that liver cell cancer that I talked about, that seems to be more common in Japan and Italy and Spain rather than in the United States. And we know that the likelihood of hepatocellular carcinoma, the HCC, well, that's increased substantially in the past 20, 30, 40 years, increased by about threefold. Probably about a third of the increase is caused by hepatitis C. And as I say, we don't exactly know what causes the liver cell cancer. Maybe it's the inflammation, maybe it's the fibrosis, or maybe it has to do with an interaction of some of the virus particles itself. But we know that we can monitor you. We can monitor your liver to see whether it's got new kinds of problems. We can do ultrasound examinations, and we can do them maybe yearly. It used to be that we would do a test for a particular kind of chemical known as alpha-fetoprotein. It's thought that that's probably not a great idea anymore, doesn't really give us any great information. But it's thought that if we find that the fibrosis is continuing, well, then it's thought that maybe we'll be able to begin therapy with one of the newer drugs, and if we begin therapy with some of the newer drugs, then we might be able to prevent the progression. Now, here's an issue. The issue is if we begin therapy and if we kill the virus and if we develop a condition that we call an SVR, and it stands for a sustained viral response. We have no virus that we can find in your body. Is that tantamount to cure? Well, yeah, it means that we've taken the virus titer and we've reduced it down to we can't find it, which presumably means it's not there. On the other hand, that doesn't necessarily stop the disorder. So if you have cirrhosis of the liver and we get rid of the virus, that doesn't cure the cirrhosis of the liver. That just stops it, hopefully, from progressing too much. But you could theoretically go on. Now, if you have the hepatitis C infection, what are other things that could happen to you? And you see, it's very important to realize that the virus has receptors for cells. Now, we know that it goes to the liver, so it has a receptor, so it hones in the liver and can cause some damage in the liver. We also know that it can hone into different areas of the body. It can hone into what we call B lymphocytes, and that can cause a problem. And it also is one of those things where it makes antibodies, and for whatever reason, the body makes chemicals to the antibodies, and then those chemicals can precipitate out, especially in the cold. As it gets cold, then they can precipitate out, and we call that mixed essential cryoglobulinemia. And in many cases, that's a result of hepatitis C. It also could be the result of hepatitis B. We also know that it can lead to a vasculitis. It can affect the brain, it can affect the nerves, it can cause some bleeding in the skin, it can cause some joint problems, it can cause some weakness. We also know that, as I mentioned a moment ago, that the hepatitis C virus hones into the B lymphocytes. That's a type of white blood cell that makes antibodies. Well, when it does that, it may induce some sort of a tumor, and we call that Non-Hodgkins Lymphoma. And that can develop. And certainly, it seems to be able to do certain things to the skin. It can cause lichen planus. It can cause Raynaud's phenomenon, where a person gets very cold in the skin, especially the hands and the feet, they can turn white and then red and then blue. We know that you can develop a problem where the sweat glands or the salivary glands aren't working. We know that the condition can cause rheumatoid arthritis, and also certain endocrine disorders are much more common in hepatitis C patients. So diabetes is more common, and hyper and hypothyroidism, either an excess or under amount of thyroid hormone common, and certain kind of other issues where a person can develop an inflammation of the blood vessels. We call it a vasculitis, and that can affect the kidneys. All of that is possible. Well, if a person develops the infection, we can follow them through a variety of tests, either blood tests or a variety of other kind of tests, in order to determine who is progressing and who needs the therapy. Well, what do we know about the virus itself? We know that the virus, the hepatitis C virus, has different types. So we know not all viruses are alike. In standard classification, there are 6 types of hepatitis C virus. However, we know that at least 11 types exist, and as a matter of fact, there are at least 50 different subtypes and at least 100 different strains of the virus on top of all of that. So you can see the permutations are extraordinarily broad. Now, if we look at evaluating the virus, we know that we find that certain strains seem to be more likely to cause problems than other strains. Certain strains seem to be more difficult to treat. So the kind that's the most prominent in the United States, we call it the genotype 1, is much more difficult to treat than genotype 2 or 3 or many of the other types of viruses. We know that if we look here in the United States, probably somewhere around 2/3 of all viruses are genotype 1. And we have genotype 1A and genotype 1B. Well, it makes a difference as far as the therapy with ribavirin is concerned, but when we're talking about the more modern therapies, the therapies instead of 2011, if we're talking about 2015, well, it doesn't seem to make all that much difference. Genotype 2, genotype 3, these are present a little bit here in the United States, but they're more prevalent overseas. If we look at genotype 1, overall, it causes about half of all hepatitis C in the world. If we look at genotype 2, maybe about 10-15%, genotype 3, maybe about a quarter of all of the cases, genotype 4, the kind that we talked about a while ago involving Egypt, well, that's about 10-15% of all hepatitis C, and the genotype 5, genotype 6, just a couple percent. Now, genotype 1, the kind prominent here in the United States, is also prominent in Northern Europe. It's also prominent in Latin America, in Australia, in Asia. Counts for at least 50%, maybe as many as 75% of all of the viral type infections. If we look at genotype 2, on the other hand, it's more common in Europe and North Africa. If we look at genotype number 3, it's much more common in Asia. If we look at genotype number 4, remember we talked about that as being very common in the Middle East, especially in Egypt. If you talk about genotype number 5, it's more common in South Africa. If you talk about genotype number 6, more common in Asia. So these viruses differ, and they differ significantly in their genetic makeup. And because they differ significantly in their genetic makeup, that means that some of them are much more difficult to treat than others. Now, there's been a long history that the virus has been associated with man. The virus is an RNA kind of virus. It makes one protein, and the protein's kind of long. It's about 3,000 amino acids, and it's divided in the body into 10 different structures. Some of those are what we call the regulatory proteins, and others are what we call the non-structural proteins, so structural and non-structural proteins. Now, different kind of sequences that are somewhat related are also present in horses and dogs and rodents and birds. It belongs to what we call the flavivirus family. It has some other closely related viruses, the hepatitis G virus, the yellow fever virus, the dengue virus, and as we said, that the virus seems to hone in specifically to the liver or to the B lymphocytes. That's the type of white blood cell, the kind of white blood cell that makes the antibodies. Now, when we're talking about how many liver cells are infected, it used to be thought that the hepatitis C virus didn't affect all of the liver cells. It actually affected relatively few, a small percentage of liver cells, 5, 10, 15%. But now it's thought that maybe as many as half of the liver cells might be infected. Well, when the virus infects the liver and the blood cells try to eliminate the virus, that means that you could have a battleground in the liver, and that's what causes the type of subclinical hepatitis. That's what causes an abnormality of the blood test that is very frequent, but doesn't rise to the level of any clinical disease in the overwhelming majority of people. So you have the virus in the liver, and you have trillions of viral particles in the liver. But for the most part, aside from living copacetically with the body's immune system, the body's immune system makes some antibodies to it, and the antibodies don't seem to be able to achieve much success over the virus. In fact, they might cause the virus to mutate. But for the overwhelming majority of people, that battleground isn't going to cause significant problem. But in some people, because of the genetics of either the virus or the person, there might be progression to more severe inflammation that could lead to cirrhosis and then the other problem, the problem with the liver cancer. Well, that big protein we said that was made by the hepatitis C, that virus is going to lead to a structural protein. And there are 3 structural proteins, and we call the structural proteins core or E1 or E2. E stands for envelope. So we have these proteins, the structural, and then we have some non-structural proteins, and the non-structural proteins significant in number, and those are the chemicals, those are the areas that are important for viral replication, and they're important for the defense of the virus, and those are the areas that our new therapies attack. Those are the areas on the virus that are specifically targeted by the new therapies that are able to achieve success over the virus. Now, if we look at the E2 site, the E2 site causes us lots of problems. It seems that that's where the receptor is. So the virus makes a protein, and part of that protein is responsible for sticking to the liver cell and sticking to the lymphocyte. We know that there's a lot of variation on this particular area, on the E2, so that the body, when it tries to make antibodies to the virus, can't eliminate it because there's a high rate of mutations. We also know that on the non-structural protein, we call it 5A, that's clinically significant. At least at one point in time it was clinically significant because that's what determined whether the interferon, and the interferon up until 2011 was a standard treatment for hepatitis. Well, up until then, the non-structural 5A protein was the determinant of whether the interferon was going to work or whether it wasn't going to work. And then in addition to all of that, we have on those other areas of the non-structural protein, we have things like helicase, and we have the proteases, and we have the polymerases, and all of those things, all of those chemicals, all of those areas of the viral protein are responsible for the mischief that the virus causes and the likelihood that we're going to be able to successfully eradicate it. Now, in the blood, we have lots of what we call quasi-species. Quasi-species because the virus makes a lot of mistakes. The virus doesn't have a good proofreader, and as a result, when the virus tries to replicate itself, and it does it very rapidly, it doesn't have enough time to check the virus to only produce identical copies. So when it produces copies that aren't identical, number 1, they get in the system. Number 2, they evade the body's immune system. Now, We know that a significant number of virus particles are manufactured in any given day. As many as 10 trillion virus particles can be manufactured. And as a matter of fact, the rapidity of the viral manufacture, or the viral replication, is responsible for all of these quasi-species, and that causes some difficulty in getting rid of the virus. So what is the likelihood the body's immune system is going to be able to take care of the virus? Well, as we already mentioned, it's not all that great. And as a matter of fact, the likelihood of you getting rid of the virus is only about 20–25%. The rest of the time, the virus is going to stay with you forever. Now, the question is, if you have an infection with one type of hepatitis C virus, could you theoretically become infected with another kind of hepatitis C virus? Oh, unfortunately, the answer is yes. And once you're treated, you do get no long-term benefit. You do have no protection. In the other types of hepatitis A, for instance, or if we're talking about other kinds of viral infections like the measles or the mumps, we can give you a vaccine, or you can become infected, and then you're protected against another bout of the condition. Here in the case of hepatitis C, that is not the case. Now, the good news is that they're working on a virus, and the virus has to do with the ability to stimulate some of those T cells that we mentioned, the T cells that are around the liver, the T cells that might become stimulated to cause inflammation inside the liver and then cause some complications. But we do know that if we get there first, with a vaccine, we might be able to be successfof. That's a subject to be discussed down the road a piece when we get a little more information. But right now it's in the early stages of testing. Well, we'll take a break and we'll be back next week, and we'll talk a little bit about the cost of treating the virus and deciding who actually needs to be treated. I thank you for watching. We'll be back soon. I'm Dr. Ken Landau.